Okay, let's unpack this. We're diving straight into a world defined by immense responsibility, profound knowledge, and this deeply human connection. It all starts with a statement from the 1950 edition of Harrison's Principles of Internal Medicine that really sets the tone.
Yeah, it says, no greater opportunity, responsibility, or obligation can fall to the lot of a human being than to become a physician.
Wow, that's heavy.
It is. And that quote isn't just words. It really encapsulates the sheer scale of what the medical profession asks of someone. It's a recognition that it's not merely a career, but a calling.
A calling that demands, well, not just the technical stuff, right?
Exactly. Not just sharp technical skills and scientific knowledge, but perhaps most crucially, a deep human understanding.
And that human understanding seems key. The sources we're drawing from, excerpts from Harrison's, other material on promoting good health, they constantly bring us back to the patient.
Right, not as just a collection of symptoms or body parts, but as a whole person.
A person who's probably scared, hopeful.
Yeah, fearful, hopeful, seeking relief and reassurance in a moment of real vulnerability.
So our mission for this deep dive is to take this stack of sources and really pull out the most important nuggets, the enduring values, the seismic shifts, the essential skills.
Think of it as a shortcut, helping you gain a truly deeper understanding of this vital and complex field. Moving closer to mastering the information, like the professionals who navigate it every day.
Okay, so starting with that core idea from 1950, technical skill, scientific knowledge, human understanding, seeing the patient as human. 70 years later, medicine has changed in ways they probably couldn't have even imagined.
Oh, absolutely. The scientific landscape has transformed. I mean, we've seen an explosion of knowledge. It's driven by incredible advances in molecular genetics, new imaging tech that gives us these unprecedented views inside the body.
Like MRI, CT.
Exactly. And robotics, bioinformatics, IT woven into everything. It's fundamentally reshaped how medicine is practiced,
Yeah.
from how we even define diseases to how we treat them.
And that pace of scientific growth, it feels relentless. We're swimming in data now, EMRs, the internet.
It's a tidal wave of new tools and facts.
And yet what's fascinating here is that despite 70 years of that kind of revolutionary scientific progress, the ultimate goals, they're still the same, aren't they?
They really are. The original text laid it out, and it holds true. We're still aiming to prevent disease, diagnose it early, and treat it effectively.
And that critical element, the trusting relationship between physician and patient.
Still absolutely central. The sources repeatedly underscore that. All the technology enhances it, sure, but it doesn't replace it. It can't.
That really highlights the essential balance, doesn't it? The sources talk about the science and the art of medicine working hand in hand. Let's zoom in on the science first. How do things like deductive reasoning and applied technology form that bedrock?
Well, the scientific foundation today is incredibly strong. We have these amazing advances in core biology, biochemistry, cell biology, immunology, genomics.
The real fundamentals.
Right. Combine that with imaging like MRI and CT scans, and it's like having these powerful lenses to look inside the body, even down to the cellular level. We can probe the innermost workings of cells.
It sounds almost futuristic compared to just a few decades ago.
It really is. Researchers are untangling the unbelievably complex ways genes are controlled. Clinicians are grappling with how subtle variations scattered across many different genes working together can impact how a body or even a single cell functions.
Wow.
And we're learning about the critical role of stem cells, not just in development, but in normal tissue repair, disease processes like cancer, and as potential therapeutic tools. It's huge.
And entirely new ways of looking at biology have emerged too.
Absolutely. Think about the human microbiome, that vast ecosystem of microbes living in or on us. Their collective genes outnumber our own by millions.
That's staggering.
And we're discovering they are fundamental to everything from immune system development and metabolic balance to brain function and how susceptible we are to certain diseases.
Well, epigenetics, that's
Yeah.
another big one, right?
Huge. Understanding how gene activity is regulated without changing the DNA sequence itself. It explains why different cells in your body with the same DNA behave so differently, and it's linked to many diseases. Then there are non-coding RNAs, proteomics, studying the entire protein landscape.
Proteomics, so all the proteins.
Exactly. Metagenomics, looking at environmental species influencing our biology. Metabolomics, studying the chemical fingerprints of health and disease.
Okay, whoa, that's a lot of omics and complex terms. What's the big picture takeaway from all that? For someone trying to grasp this, what does it all mean?
Good point. It's easy to get lost in the jargon. The real takeaway from this explosion of omics is that we're moving from a simpler, more generalized understanding of disease
Mm?
to recognizing its incredible complexity and individuality. These fields generate massive data sets, big data.
From the omics themselves and also from things like electronic medical records.
Exactly, and that's where things like AI come in. Analyzing that big data effectively requires sophisticated tools like machine learning and artificial intelligence.
To find patterns humans might miss.
Exactly. These tools help us find patterns, predict outcomes, analyze information in a more unbiased way than a single human brain ever could. The knowledge from all this science doesn't just enhance our understanding. It provides entirely new avenues for prevention, diagnosis, and treatment.
And the sources mention a practical application, precision medicine.
Yes, moving towards precision medicine, where we combine these biological signatures from the omics with a deep understanding of how a disease actually manifests in a specific patient, what they call pathophenotypes.
Could you give a concrete example of how this science has had a real-world impact recently, something tangible?
Vaccinology is a fantastic example. The unprecedented speed and success in developing the COVID-19 vaccine.
Right, that was incredibly fast.
That wasn't just luck. It was built on decades of fundamental science in vaccine platform technology and cutting-edge tools like cryo-electron microscopy. That allowed scientists to see viral structures at an atomic level and design vaccines based on that. Pure science leading to a rapid, life-saving solution.
Okay, so that's the mind-blowing science side. But the sources also talk about the art. How does the physician take all this immense scientific possibility and apply it while dealing with a real person, a complex clinical problem?
This is where the art is indispensable. When a patient walks in with a complex set of symptoms, the physician has to apply all that scientific knowledge, sure. But first, they need to identify the most crucial pieces of information from a detailed conversation, the history and the physical exam.
Filtering the signal from the noise.
Precisely. They have to decide which tests are the right ones to order, avoiding unnecessary procedures but not missing something vital. And then they need to pull the key findings out of what can be incredibly dense, multi-page computer screens filled with lab results and reports.
And knowing what's important versus what's just background static.
That is a core part of the judgment, the art. With more tests done, you will find incidental findings, things that show up but aren't related to the main problem.
The incidentalomas.
Exactly. Deciding if a clinical clue is truly significant or just a red herring is a critical judgment call. Weighing the potential risks of a test or a treatment against the actual risk posed by the disease itself, these require a different kind of skill than just scientific knowledge.
So how do the sources define this essential art?
They define it as a blend of medical knowledge, yes, but also intuition, accumulated experience, and seasoned judgment.
Experience really counts.
Immensely. And they are very clear. This art is just as essential to the practice of medicine today, in our high-tech, omics-rich world, as a sound scientific base. It was important 70 years ago, and it's just as important now, maybe even more so, to integrate it all.
So mastering that art requires honing specific clinical skills. Let's take a deep dive into history taking first. It sounds basic, but the sources suggest it's anything but.
History taking is the absolute foundation. It's about gathering all medically significant facts, yes, focusing on recent events, but it's also about creating an environment where the patient feels comfortable telling your story fully and without interruption.
So letting the patient talk.
Absolutely. The physician's interest, their encouragement, their empathy, these are crucial. Sometimes, a seemingly trivial detail the patient offers, almost as an aside, turns out to be the key to unlocking the diagnosis.
It's definitely more than just a checklist then.
Much more. A methodical review of systems is still important, asking about every body system to catch things the patient might not have thought to mention. But it's the patient's comfort level, the trust built with the physician, that allows them to provide truly complete information.
And paying attention to nonverbal cues, body language.
Hugely important. Tone of voice, gestures, it gives invaluable insight into their perception of their illness and their emotional state.
Yeah.
And because memory isn't perfect, especially when someone is ill or stressed, trying to corroborate key parts of the history when possible is important.
And the social and family history play a big role too.
Absolutely vital. Social history helps understand the context of the illness and practical considerations for management, things like their living situation, their job, their support system. You need to know that.
And family history.
Genetics, right? Not just rare genetic conditions, though that too, but assessing risk for very common and important diseases like heart disease, hypertension, diabetes. autoimmune disorders, allergies, asthma. For a truly comprehensive picture, you might even need input from multiple relatives.
And the history often shapes the rest of the diagnostic process. It kind of sets the direction.
Yes, definitely. An experienced clinician can often formulate a relevant differential diagnosis, the list of potential conditions they're considering almost entirely from the history alone.
Wow.
The physical exam and diagnostic tests then become tools to refine that list, to either narrow it down or sometimes to reveal something completely unexpected that sends the physician back to ask more questions.
It sounds like taking the history also builds something else important, something relational.
It does. The very act of listening to the patient's story is where that unique bond, the patient-physician relationship, is established or deepened. It's how the physician begins to truly understand the patient's perspective on their illness, their fears, their expectations, the practical impact of being sick on their life.
And the sources warn against rushing this.
Strongly. Even with time constraints, rushing can make patients feel unheard, causing them to withhold potentially crucial information. And of course, confidentiality is a sacred trust here, absolute bedrock.
Okay, so history is foundational. What about the physical examination? What's its purpose today, especially with all the technology we have, the fancy scans and tests?
Well, the primary purpose is still to identify objective physical signs of disease, things the physician can see, hear, or feel. These signs often confirm something suggested by the history, but sometimes they're the only evidence that something is wrong.
And it needs to be systematic. You can't just poke around randomly.
Rigorously so, methodical and thorough. For a new patient, it's typically a head-to-toe examination, a systematic search for abnormalities, always respecting the patient's comfort and privacy, and, importantly, recording the findings immediately before memory fades or distorts.
How do physicians even learn these skills? It seems like it takes a lot of practice.
It does. The sources highlight that these skills are traditionally learned under the direct guidance of experienced physicians, observation, coaching, feedback. Modern methods include simulation labs and using standardized patients to practice.
Standardized patients, actors.
Essentially, yes,
Yeah.
trained actors who simulate patient cases. But beyond having keener senses, the sources stress that success comes from having an alert mind, being prepared to spot subtle findings that might otherwise be missed, like a few tiny spots of bleeding under the skin, a very faint heart murmur, or a small, hard lump.
Things easily overlooked.
Exactly. And physical findings can change over time, so repeat exams are often necessary.
Now, with all the sensitive imaging and lab tests available today, is there a risk that the physical exam gets less attention? The sources mention this tension, right?
Yes, they absolutely address the temptation to de-emphasize the physical exam, especially with critiques about its sensitivity or specificity compared to technology. And it's true that consultants might see patients only after a battery of tests are already done.
But the sources push back on that.
Strongly. They emphasize that important findings do escape detection by diagnostic tests, and a thoughtful physical exam can actually change the significance of a lab finding. For instance, hearing a characteristic murmur on exam might make a small heart valve lesion seen on an echo seem less concerning than it would be otherwise.
Context matters.
Immensely. They firmly reinforce the physical exam's foundational role, not just in diagnosis, but as a crucial part of building that patient-physician relationship, that hands-on connection.
Okay, moving into the modern practice. Medicine isn't usually practiced in isolation anymore. It's increasingly team-based.
That's a massive shift, although teams in medicine have existed for a long time with nurses and doctors. But the increasing complexity of managing patients, say in ICUs or transplant units.
Or just chronic illness.
Exactly. Chronic illness, where a patient might have multiple conditions and specialists plus their primary care physician, makes effective teamwork absolutely essential. Nurse practitioners and physician assistants are vital parts of these teams now, too.
How does this teamwork actually function day to day? Is it all through the computer?
It requires communication and not just relying on the electronic chart. Face-to-face or phone conversations are necessary, especially for complex cases or difficult decisions. A key challenge is ensuring everyone on the team is giving consistent messages to the patient.
And that team includes more than just doctors and nurses.
Oh, yes. Pharmacists, social workers, physical therapists, occupational therapists, allied health professionals are absolutely vital. They contribute not just to clinical care, but hugely to the patient's overall experience and progress.
What are the implications of this shift towards teamwork?
They're significant. It affects the culture of medicine, how future professionals are trained. Interprofessional teamwork is now a curriculum focus, and how entire healthcare systems are organized. the biggest single challenge they note. Effective communication within these teams. It's about balancing the efficiency of electronic tools with the critical need for direct human conversation.
Let's look at the hospital versus outpatient setting. There's a big difference, and that landscape has changed dramatically too.
It's changed enormously. Emergency departments and critical care units can now save patients who simply wouldn't have survived previously. But at the same time, there's intense pressure, driven by cost considerations, to reduce hospital stays.
And manage more stuff outpatient.
Right. Manage even quite complex conditions in the outpatient setting. New outpatient technologies and evidence showing better outcomes for some conditions treated at home are also driving this shift.
And hospitals themselves are more complex with different levels of care within them.
Definitely. You have the ED, procedure suites, observation units, step-down units, critical care units, dedicated palliative care units. This specialization has led to the rise of new medical specialties like emergency medicine and end-of-life care.
And new roles like hospitalists.
Exactly. Hospitalists, internists focusing exclusively on inpatient care and intensivists who are certified critical care experts.
This sounds like it creates potential challenges when patients move between these different settings or teams. The idea of patient handoffs.
That's a critical challenge identified in the sources. The smooth transfer of information and responsibility between a patient's primary doctor and the hospital team, or between different teams within the hospital.
Like ICU to the regular floor?
Precisely. Or even from hospital back to home care. It's complicated by these handoffs. When responsibility passes from a physician who knows the patient intimately to one who knows them less well, it poses a potential threat to continuity of care and that traditional patient-primary physician relationship.
How does the primary physician navigate this? How do they stay in the loop?
Well, while collaboration is essential and benefits the patient, the primary physician still has a crucial duty to provide cohesive guidance through this potentially fragmented system. They need to understand what the specialists are doing, ensure the patient is truly benefiting from that expertise.
And explain it all to the patient.
Yes, explain the roles of these different doctors to alleviate anxiety and assure the patient that decisions are being made with input from their primary physician. The evolving concept of a medical home is an attempt to create a more integrated environment to smooth these transitions.
Shifting focus slightly, the sources really emphasize the patient experience of illness, particularly in the hospital. It sounds like that's a big area of concern.
It's a key point. Few people are prepared for a serious or acute diagnosis. The fear, the distress, the sheer emotional upheaval can complicate their care. Physicians and providers play a vital role in mitigating this.
How? By providing information.
Yes, providing information calmly, clearly, consistently, and with reassurance. The sources note that information often needs to be repeated along with that reassurance because patients are often too stressed to absorb it all the first time.
And the hospital environment itself can be incredibly stressful and bewildering from a patient's perspective.
Absolutely. Imagine being thrust into an unfamiliar environment filled with strange equipment, tubes, wires. You encounter a seemingly endless stream of staff members, hospitalists, specialists, nurses, aides, PAs, social workers, technicians, therapists, students, residents, attendings, consultants.
Wow, just listing them is overwhelming.
Right, and people just there to transport you to a test. You might be moved frequently, sometimes left alone, share a room with strangers. It's a lot to process when you're feeling vulnerable.
And the illness itself adds to that confusion.
Yes. Acute illness, combined with an unfamiliar place, multiple new medications, and often significant sleep deprivation, can easily lead to confusion or delirium, especially in older patients. It makes an already difficult situation even harder.
So a physician appreciating this perspective makes a real difference.
A huge difference. Physicians who truly understand the patient's perspective of the hospital experience and make an effort to guide them through it can transform a terrifying situation into something more tolerable. This understanding and compassionate guidance can significantly enhance the patient's chances for an optimal recovery. It's about acknowledging the human being grappling with illness, not just the disease in the bed.
Okay, let's move to what feels like a core pillar of practice: medical decision-making. This seems fundamental.
It is absolutely fundamental. Physicians are constantly making decisions at every stage: diagnostic decisions about which test to order, therapeutic decisions about which treatments to give, prognostic decisions about what the future might hold. It requires a deep understanding of how diseases work and how they typically progress.
How does a physician arrive at a diagnosis? Is it just pattern recognition?
It's more systematic than that. Ideally, it involves applying broad medical knowledge and assessing the likelihood of different conditions given the patient's specific presentation, building that differential diagnosis. It's essentially applying the scientific method.
Hypothesis testing.
Exactly. Formulating hypotheses, possible diagnoses, collecting data, history, exam tests, and then accepting or rejecting those hypotheses based on the evidence. And it's iterative. New information constantly refines the list of possibilities, contracts it, or expands it.
And the sources heavily emphasize evidence-based medicine, EBM.
EBM is critical. Ideally, decisions should be based on the best available evidence from rigorous studies and objective comparisons, moving away from decisions based solely on individual, potentially biased experience or anecdote. EBM is important and has led to the development of practice guidelines.
But is it always possible to base every decision on strong evidence? Are there always clear trials?
The sources are quite direct here. No, only a small fraction of clinical decisions are actually based on rigorous, high-quality trials. Many others rely on the consensus of experts or evidence that is less definitive, maybe observational studies or case series.
So that's where judgment comes in.
This is precisely where good clinical judgment becomes indispensable. It's the physician using their knowledge and experience to weigh all the factors, the uncertainties, and make the soundest decision possible, especially when clear EBM guidance isn't available. This judgment is difficult to quantify, but it's vital.
Are there quantitative tools to help with decision-making beyond just judgment?
Yes, absolutely invaluable ones. Diagnostic tests themselves are tools to reduce uncertainty. Concepts like Bayes' theorem allow physicians to update the probability of a diagnosis as they receive new test results, using prior knowledge.
So combining prior belief with new evidence.
Mathematically, yes. Multivariate statistical models can help analyze complex sets of data. And understanding the accuracy of diagnostic tests, things like sensitivity, correctly identifying disease, specificity, correctly ruling out disease, and the predictive value of a positive or negative result is part of using these tools wisely.
What role do practice guidelines play then? Are they the answer?
Guidelines, developed by professional organizations or government agencies, are intended to help physicians make evidence-based, cost-effective, and appropriate decisions. They provide a useful framework for managing patients with specific conditions.
And they have benefits.
Clear benefits. They can protect patients from receiving substandard care, protect caregivers from malpractice claims by ensuring they follow accepted standards, and potentially protect society from unnecessary costs.
But there are limitations to guidelines. They aren't perfect.
Yes, the sources point out significant caveats. Guidelines can sometimes oversimplify the complexity of individual patients. Different organizations can issue conflicting recommendations, which is confusing. Think controversies around screening, like mammography or PSA tests.
Right, those debates seem constant.
And guidelines cannot possibly capture the unique characteristics and preferences of every single patient. The challenge for the physician is to thoughtfully integrate the useful recommendations from guidelines without following them blindly or feeling inappropriately constrained in their judgment for an individual patient. It's a balance.
This feels like it leads naturally into the idea of precision medicine. Is that like super personalized guidelines?
It's a natural evolution, yeah. Precision medicine, or personalized medicine, is built on the recognition that even diseases that appear similar on the surface can be fundamentally different at a deeper level. We can stratify individuals based on their unique genetic makeup, biomarkers, how the disease specifically manifests clinically, those pathophenotypes again, or even psychosocial characteristics.
And the goal, why do this?
To target therapies much more precisely. The aim is to use treatments that are most likely to benefit a specific patient, leading to improved outcomes, while minimizing unnecessary side effects for those less likely to respond.
So it's like a more refined version of guidelines, moving from populations to individuals.
Yes, you can view it as an evolution. Clinical practice guidelines are often for populations. As our understanding of subgroups within those populations grows fueled by genomics, proteomics, deep clinical phenotyping guidelines will increasingly incorporate more refined recommendations tailored to those specific individuals or subgroups.
Where are we seeing this most clearly now?
The best examples today are definitely in cancer, where genetic information routinely guides treatment choices. But it's also relevant in pharmacogenomics, how your genes affect drug response managing immune disorders, and using biomarkers to predict how someone will respond to a therapy.
How do we measure if all this is actually successful? Is it just numbers like survival rates or hospital stays?
Clinicians do use those objective measures, mortality, length of stay, readmission rates. They're important and often risk-adjusted for how sick patients were initially. However, the sources note that these objective measures can sometimes oversimplify the picture, especially for complex patients with multiple health issues.
Because patients often seek care for things that aren't easily measured objectively, like pain or just feeling better.
Exactly. They come in because they have pain or they can't function the way they used to or they want to feel better and enjoy life. The sources emphasize that subjective reasons are frequently the primary drivers for seeking care. So, assessing success also requires evaluating a patient's health status and quality of life.
How do you capture those subjective things? It seems tricky.
Through structured interviews or questionnaires. These provide frameworks for assessing subjective views and responses, which is particularly important in managing chronic illnesses, where the goal might be improving function and comfort rather than outright cure. Effective practice requires integrating both objective measures and subjective outcomes to get a full picture of success.
And healthcare systems are also looking at patient feedback now, surveys and things.
Yes, increasingly so. Things like patient satisfaction surveys like HCA-HPS in the US and feedback gleaned from social media are used to assess qualitative aspects of care, like how satisfied patients are, how easily they could access care, how well they felt they communicated with providers. This qualitative data can enrich the information used to make decisions about improving care delivery.
Patient safety is a huge focus in healthcare today. The sources mention important reports on this, things that really sounded an alarm.
Yes, landmark reports from the Institute of Medicine, now the National Academy of Medicine, really brought the issue of errors in healthcare delivery to the forefront. They called for systemic changes to improve patient safety. Hospitals and healthcare organizations have a significant responsibility to develop and implement systems to reduce risks.
What are some practical examples of how errors are being reduced? What actually works?
Medication errors are a big target. Electronic ordering systems and barcoding medications help reduce errors caused by misreading handwriting or giving the wrong drug.
Eliminating bad handwriting helps.
Definitely. Interactive computer systems can provide warnings or reminders about drug interactions or allergies. Beyond systems, physicians have a responsibility to understand the potential dangers and costs of the powerful therapies they use.
And infections.
Infection control is fundamental, rigorous hand-washing protocols, careful oversight of antibiotic use. There have been dramatic reductions in central line and catheter-related infections in many places by implementing and strictly adhering to standardized protocols. Surgical infections and on-site surgery are reduced through protocols and checklists.
Simple things like checklists make a difference.
Huge difference. And other things too, like judiciously using sedatives and ensuring assistance for patients at risk of falling helps prevent falls. These measures, implemented system-wide, are truly saving thousands of lives every year.
And technology like EMRs and the internet is central to these safety efforts, isn't it? IT seems embedded everywhere.
IT is absolutely central to the practice of modern medicine and to efforts to reduce errors. Lab results accessed electronically. Electronic medical records, EMRs, are becoming ubiquitous, enabling computerized order entry, tracking medications with barcodes, incorporating those interactive systems with warnings.
What are the big advantages of EMRs? Why have they become so widespread?
Well, for a complex patient, having rapid electronic access to their entire history, imaging, labs, consultant notes, it's invaluable for managing their care. EMRs can also help monitor and reduce unwanted variation in care across the system and provide real-time information on processes and outcomes. The ideal is easy transfer of records across different systems.
But that's still a challenge.
Technical limitations, privacy concerns, cost. There's still hurdles there, definitely.
But it's not all positive, right? There are downsides to EMRs mentioned.
Yes, significant ones. If the physician is constantly looking at a screen, it can create a physical and emotional distance between the physician and the patient. It can undermine that crucial face-to-face interaction.
The computer gaze.
Right. EMRs require substantial training and take a lot of time to use effectively. Providers spend significant time on data entry and meeting structured billing requirements. There's pressure to shortcut, like cutting and pasting from old notes, which can introduce errors or perpetuate inaccuracies.
And the structure itself can be disruptive.
It can. The structured format can disrupt the natural, chronological narrative flow of a patient's story that a traditional paper chart often provided. It can feel fragmented.
And this impacts physicians directly, their well-being.
It does. The sources note that the sheer effort, time, and attention demanded by EMR use are major contributors to physician dissatisfaction and can negatively impact their well-being. Burnout is a real issue. It's an area that absolutely needs improvement, not just for the sake of the providers, but because physician burnout can ultimately impact patient care.
So IT is powerful, but it's a tool, not the ultimate decision maker. It doesn't replace the doctor's brain.
Crucially important point. IT never replaces clinical decisions. Those require the physician's accumulated knowledge, their understanding of the patient's unique needs, supplemented by quantitative tools, but ultimately relying on their seasoned judgment. The human element is irreplaceable.
How about the internet for physicians? Is that generally seen as a good thing?
Largely a positive force, yes. It provides rapid, often instantaneous access to current medical information guidelines, conferences, journals, textbooks. It facilitates communication with colleagues globally. This access significantly lessens the information gap, especially for physicians practicing in remote areas. New research published online is available much faster than in print.
And patients use the internet for medical information a lot now, too. They come in armed with printouts sometimes.
Yes, increasingly so. Patients arrive at appointments having researched their symptoms or conditions online. They can be very well informed or significantly misinformed.
That's the tricky part.
It presents a challenge for the physician. They must not only stay current with the medical literature themselves, but also act as an editor for the patient, helping them navigate a vast amount of online information whose accuracy and validity can vary wildly.
That variability sounds like a real danger. Anyone can post anything.
It is. The sources are explicit about this critical danger. Virtually anything can be published online, bypassing traditional peer review processes. Both physicians and patients must be acutely aware of this. But despite that caveat, when used appropriately, the internet has truly revolutionized access to medical information and is a remarkable resource that wasn't available a generation ago.
Let's turn to what the sources describe as the very heart of medicine, the patient-physician relationship. They share a powerful quote from Francis W. Peabody.
Yes, the secret of the care of the patient is in caring for the patient.
Simple, but profound.
It speaks volumes. It grounds medicine in the significance of that intimate, personal relationship. It reminds us that patients are complex individuals with lives and problems that extend far beyond their physical complaints. They aren't just a case of a particular disease.
And the sources say treatments fail patients, not the other way around.
Exactly. A crucial shift in perspective. This humanistic view is absolutely vital to maintain in our increasingly high-tech world.
How should physicians cultivate that relationship? What does caring for the patient look like in practice?
Well, patients who are ill are inherently anxious and often fearful. The physician should aim to instill confidence and offer reassurance. This isn't about being overly cheerful or dismissive, but maintaining a professional attitude combined with warmth, openness, and sincere concern.
So avoiding arrogance or impatience.
Absolutely. Avoiding arrogance, being patronizing, impatient, or hurried is essential. Empathy and compassion are described as fundamental traits of a caring physician that encourage patients to share openly.
And considering the patient's background, their life context.
Critically important. The setting of the illness matters immensely. The patient's family situation, their social context, their cultural background. The ideal relationship is built on a thorough knowledge of the patient as a person, mutual trust, and clear, open communication.
Informed consent is a key part of that ethical relationship, isn't it? It seems like a cornerstone.
It is, and it reflects core medical ethics principles, always acting in the patient's best interest and respecting their autonomy. Informed consent is legally required for procedures, but ethically it's much broader.
Broader how?
Physicians must discuss alternatives, not just the proposed treatment, but other care options, their risks, benefits, potential consequences in language the patient can truly understand. It's the physician's responsibility to ensure the patient grasps this.
Which might mean repeating things.
Often means encouraging questions, repeating information gently and without judgment, and answering new questions as they arise. Patient education is an ongoing process, not a one-time event before a procedure. Fear can make understanding difficult, so clear, supportive communication is vital, especially if complications occur.
And conflicts of interest.
The sources note that the physician seeking consent should ideally have no financial or other conflict of interest related to the procedure or treatment being proposed. Transparency matters.
Approaching grave prognosis and death must be one of the most difficult aspects of medicine. How do the sources guide physicians here?
It is incredibly distressing for everyone involved. The sources directly address the challenging questions: what information to share with the patient and family, decisions about life support, how to optimize the patient's quality of life when cure is no longer possible.
Transparency is key, but how is it managed? It sounds delicate.
Transparency is essential, but it needs to be delivered compassionately and appropriately. The sources suggest that even patients who seem unaware of the gravity of their situation may have insights or misunderstandings fueled by anxiety. The patient must always have the opportunity to speak and ask questions.
So the physician needs to gauge what the patient is ready for.
A wise physician assesses what the patient wants to know and when, determining the appropriate timing and pace for sharing difficult information. Ultimately, the patient needs to understand the expected course of their illness, to make plans, participate in decisions, and understand the goal, which may shift to palliation or symptom relief and its effects.
And respecting beliefs.
Religious or spiritual beliefs should always be considered and respected. Patients sometimes find it easier to share their feelings about death with medical staff or clergy than with their own family.
So the focus shifts from curing the disease to caring for the person. That Peabody quote again.
Exactly. Primum securi first, to help. The physician provides or arranges support: emotional, physical, spiritual. This requires being compassionate, unhurried, and open. Simple human touch or laying on of hands is mentioned as beneficial. Ensuring pain is controlled, maintaining human dignity, and avoiding isolation are crucial.
It sounds like the hospital setting can sometimes work against this.
In the setting of terminal illness, the sources observe that the hospital's focus on technology, equipment, and the disease can tragically overshadow the person. The goal shifts fundamentally from cure to care. Physicians also support the family, helping them navigate grief, guilt, anger, and assuring them everything reasonable is being done.
And prognosis isn't always certain, even among the medical team. That must make communication hard.
It adds another layer of complexity. Physicians often cannot give an exact prognosis, and different team members may have differing opinions. Good communication among the providers is essential to ensure consistent information is given to the patient and family, especially when there's uncertainty. Seeking advice from experts in palliative care or terminal illness is vital to help avoid fostering unrealistic expectations.
In today's healthcare system, with cost pressures and complex administration, maintaining that humanistic core sounds like a real challenge.
It's explicitly described as a major challenge. Trends aimed at reducing costs, like managed care programs that can limit a patient's choice of physician or access to specialists, can make the experience feel impersonal.
How does professionalism fit into this? Is it just about following rules?
It's more than that. The sources mention the Charters on Medical Professionalism, which outlines 3 core principles: the primacy of patient welfare, respecting patient autonomy, and upholding social justice. While medical schools teach professionalism, personal attributes like integrity, respect, compassion are incredibly important. Organizations like the Gold Humanism Society recognize physicians who exemplify this.
What defines a humane physician, according to the sources?
Qualities like availability, showing sincere concern, taking the time to explain things clearly, and maintaining a non-judgmental attitude towards patients from diverse backgrounds or lifestyles. Physicians also need self-awareness.
Awareness of their own biases.
Yes, they must be alert to their own emotional responses to patients, positive or negative, and consciously monitor and manage their behavior, always ensuring the patient's best interest is the primary driver, and truly appreciating a patient's quality of life. That requires getting to know them.
On a deeper level.
Exactly. It requires detailed, often intimate knowledge gained through unhurried, sometimes repeated conversations to understand what that specific patient values most. Time pressures constantly threaten this, but understanding and helping them achieve their priorities is fundamental to good care.
Let's shift gears again to the expanding frontiers of medicine. We talked about omics earlier. Let's delve a bit deeper into what these fields mean for practice. It's where a lot of the cutting-edge science is.
Right. The sequencing of the human genome in 2003 was a landmark event that ushered in this era. Its clinical implications are already being seen. The ability to rapidly sequence viral genomes like H1N1 or COVID-19 was crucial for swift vaccine development.
We saw that firsthand.
Analyzing gene expression profiles from a patient's tumor can help guide cancer therapy and predict outcomes. Genotyping can assess an individual's risk for certain diseases or predict how they might respond to a specific drug. But it's important to remember it's still relatively early days. Many common conditions are complex, influenced by multiple genes interacting with each other and with the environment.
You mentioned several omics fields before. Could you maybe elaborate slightly on just a couple more to show the different layers of understanding they provide, like epigenetics?
Sure. Think about epigenetics. This looks at alterations that influence gene expression without actually changing the underlying DNA sequence. Things like chemical tags on DNA or proteins around DNA can switch genes on or off. This is crucial for understanding why different cells in your body, all having the same DNA, behave so differently, like a muscle cell versus a nerve cell, and how environmental factors can impact gene activity. It's linked to cancers, aging, many chronic diseases.
Okay, and maybe proteomics.
Proteomics, the study of all the proteins in a cell, tissue, or organism. Proteins are the workhorses of the body. They can be modified after they are made, or different versions can be produced from the same gene. Studying proteins gives us a picture of cellular activity that goes beyond just looking at the genes and can reveal specific proteins that serve as markers for diagnosis or predicting disease course.
And the microbiome feels like a whole new world opening up. Like we have passengers we didn't know were so important.
It absolutely is. The microbiome, all the microbes in and on us, and metagenomics, studying their collective genes, have revealed these tiny organisms are critical partners in our health. They play roles in maturing our immune system, extracting energy from food, producing vitamins, influencing our mood, even affecting our susceptibility to diseases.
And environmental factors like antibiotics can mess with it.
Big time. Antibiotic use, diet changes.
Hmm.
They're tied to disorders like obesity, metabolic syndrome, autoimmune conditions, through their impact on our microbial partners.
That's incredibly complex. How do physicians keep up and apply this? It feels like drinking from a fire hose.
That's the major challenge the sources highlight. These advances are happening so rapidly, and the patient variability is so high. It creates challenges even in simple things like defining early disease states. Tools like systems biology and network medicine are being developed to apply to this big data from the omics to help classify diseases in new, more precise ways.
And the physician's role in all this omics stuff.
They play an absolutely vital role. Not necessarily as the scientist generating the data, but in applying these powerful technologies and the resulting information judiciously to the care of individual patients. The speed of change means continuous learning isn't optional. It's fundamental.
Especially with things like genetic testing.
Exactly. Providing wise counsel, explaining the value, the limitations, the implications for the individual and their family requires careful knowledge and judgment from the physician.
There's also the aspect of medicine becoming increasingly globalized. It's not just local anymore.
No, definitely not. Physicians today need awareness that diseases and healthcare extend far beyond local borders. Global travel means infectious diseases can spread rapidly. The Zika outbreak is mentioned as an example. Factors like wars, mass migration, climate extremes are altering disease profiles globally.
And patients travel for care, too.
Patients can also access expertise or participate in clinical trials far from where they live.
And the internet has transformed that global aspect, too, connecting everyone.
Hugely. It's completely changed how medical information is shared globally. It enables the transfer of technical skills, facilitates telemedicine consultations across vast distances, allowing international consultation for things like interpreting complex radiology or pathology.
Becoming and being a physician sounds like a truly lifelong journey of learning. There's no end point.
It's definitely that. The Flexner Report over a century ago emphasized science blended with clinical skills. Today, curricula are constantly evolving to emphasize not just knowledge acquisition, but competencies essential for a career in the face of burgeoning information and tech.
Like teamwork and communication.
Teamwork, communication, understanding healthcare systems, professionalism. Lifelong learning is built into the curriculum from day one.
And the tools of the trade keep changing. It's not just stethoscopes anymore.
Constantly changing. Physicians need continuous training on new technologies, navigating sophisticated EMR systems, analyzing large data sets, using bedside ultrasound, understanding robotic surgery, interpreting advanced imaging. All of this builds towards progressing from basic competency to proficiency to mastery.
The sources also mentioned changes to resident work hours. That was a big deal, limiting those long shifts.
Yes, concerns about physician stress, fatigue, and potential fatigue-related errors led to implementing limits on the notoriously long work hours for medical trainees, reducing them from over 90 hours a week to around 80, and further limiting shift lengths for first-year residents. The intent was safety.
And did it achieve that? Did errors go down?
Well, the sources note that the evidence showing a decrease in errors specifically as a consequence of these hour restrictions is actually sparse.
Oh, really?
Yeah. And an unavoidable byproduct of shorter shifts is an increase in the number of patient handoffs, those transitions of care.
Which we already identified as a challenge.
Exactly. It's highlighted as a critical challenge. The imperative is that these handoffs must be managed with extreme care and thoroughness. All relevant information must be clearly exchanged and acknowledged, because responsibility passes from someone who knows the patient well to someone who knows them much less intimately. Managing effective handoffs is presented as a real challenge in reliably measuring physician effectiveness today.
This reinforces the idea of the physician as a perpetual student. You can never just rest on your laurels.
Absolutely. Graduation from medical school is really just symbolic. Physicians must embrace the role of being a perpetual student. It's exhilarating, applying constantly expanding knowledge, but it's also anxiety-provoking because you quickly realize the scope of what you don't know is vast and ever-growing.
So you have to channel that anxiety.
The responsibility is to channel that anxiety into the energy needed for continuous self-improvement. Actively pursuing new knowledge, reading journals, attending conferences, learning from colleagues, using online resources is difficult for busy practitioners, but it's a commitment integral to being a physician and must be given the highest priority.
And the physician has a role beyond the individual patient, a role as a citizen.
Yes, the physician as citizen. Practicing medicine is a privilege, a noble calling. The relationship with the patient has an inherent imbalance of power, and physicians must be acutely aware of their impact, strive to strip away their own biases, and always prioritize what is truly best for the patient.
And serving the community.
Yes, promoting public health, and being willing to provide care even when financial compensation isn't available. It's part of the professional obligation.
Research and teaching are also presented as fundamental parts of being a physician, not just treating patients.
They are deeply intertwined with practice. The word doctor itself comes from the Latin docere, meaning to teach.
Ah, I didn't know that.
Physicians are inherently teachers, sharing knowledge with colleagues, students, and patients alike. The entire practice of medicine relies on the sum of accumulated medical knowledge, which comes from an unending chain of discovery, observation, analysis, interpretation.
And that process relies on research to build the knowledge base.
Exactly. Advances in medicine depend on acquiring new information through research. And improved care for patients requires effectively transmitting that information to those who need it. The sources mention a societal responsibility to encourage patient participation in ethical, approved clinical investigations,
As long as it's safe for the patient.
provided it doesn't expose them to undue hazard, discomfort, or inconvenience. Ethical considerations are paramount.
Especially regarding conflicts of interest.
Physicians involved in research must be constantly vigilant about potential conflicts between the goals of the research and their fundamental obligations to their individual patients. The patient's best interest must always take precedence. Always. William Osler, a giant in medical history, captured this ambition beautifully. To wrest from nature the secrets which have perplexed philosophers in all ages, to track to their sources the causes of disease, to correlate the vast stores of knowledge that they may be quickly available for the prevention and cure of disease, these are our ambitions.
That idea of making knowledge quickly available for prevention and cure brings us to the final section, the increasing focus on preventing disease and promoting health. This seems like a major shift.
Prevention is presented as a hallmark of excellent medical practice and a key metric for how well healthcare systems are functioning. The ultimate goal is to avoid disease from starting in the first place. With people living longer, the emphasis is shifting from just extending lifespan to preserving health span.
Health span, the number of years lived in good health.
Exactly. With a high quality of life. This leads to the concept of compression of morbidity.
Compression of morbidity, squashing the bad years.
Kind of, yeah. The idea is to reduce the burden and time spent with disease or disability towards the very end of life. The sources describe the squaring the curve concept. Instead of a slow, gradual decline in health over many years, the aim is for people to maintain good health much later in life. So the period of significant illness is compressed into a much shorter time just before death.
So, living well longer and being sick for less time at the end?
That's the ideal.
The sources outline 4 levels or strategies of prevention. Can we walk through those?
Sure. Tertiary prevention is immediate action to prevent imminent death or severe disability in someone with an acute illness. Think rushing someone having a heart attack to the cath lab for an angioplasty, acting right now on an existing acute problem.
Okay, then secondary.
Secondary prevention is aimed at avoiding recurrence of disease or death in someone who already has the condition, like giving tamoxifen to someone who has had breast cancer to prevent it coming back, or aspirin after a heart attack.
Preventing it from happening again. Makes sense. Primary.
Primary prevention focuses on reducing the risk of a disease developing in the first place in individuals who have risk factors, like treating someone's high blood pressure before they have a heart attack or stroke, or vaccinations.
Stopping it before it starts if risk factors are present. And then there's the fourth, primordial prevention. That sounds foundational.
It is. This is the furthest upstream approach introduced back in 1979. It aims to prevent the development of risk factors themselves.
So preventing high blood pressure from ever developing, not just treating it once it's there.
Exactly. It emphasizes factors like healthy eating patterns, regular physical activity, not smoking, and addressing broader environmental and social determinants of health. It involves individual medical guidance, but relies heavily on public health initiatives and social policy changes. The sources call it the ultimate means to reduce the burden of chronic disease.
Why is this primordial level considered so powerful? Why is stopping the risk factor itself so key?
Because the sources make a very strong point.
Why?
Once risk factors develop, it's incredibly difficult, often impossible, to restore a person's risk level to that of someone who never developed the risk factor at all.
Even if you treat it well.
Even when risk factors are treated and controlled, the time spent with adverse levels often causes irreversible damage to organs. The example given is treated hypertension. Even with optimal blood pressure control using medication, those patients still have double the risk of cardiovascular events compared to people who maintained optimal BP their entire lives without needing medication.
Wow, double the risk even when treated.
Yeah, because the damage to the heart and blood vessels was done during the period of high pressure. It powerfully illustrates the benefit of preventing the risk factor from ever appearing in the first place. It's a profound insight.
Wow, okay. We've covered a tremendous amount of ground in this deep dive. I mean, from the timeless human values and that essential blend of science and art, through the complex realities of modern team-based care, the challenges and opportunities of technology, patient safety, the cutting-edge frontiers of omics.
Right, all those mimics.
And landing on the crucial importance of shifting our focus to prevention at all levels, especially that primordial prevention.
It's a vast and constantly evolving landscape. By systematically unpacking these sources, you've gained, hopefully, a deeper understanding of the multifaceted nature of medicine. The knowledge required, the skills demanded, the profound responsibility involved. It truly is a profession that requires lifelong learning and a commitment to mastering new information and approaches.
Indeed. And as we wrap up this exploration, let's leave you, the listener, with a final thought to consider. In a world where technology and scientific data are advancing at an exponential pace, and where systems and guidelines are becoming increasingly complex, where does the enduring art of medicine, that core of human understanding, empathy, and the patient-physician relationship, find its greatest and most indispensable role in shaping the future of health and healing?